afternoon, everyone. So we were about to discuss how we understand semen analysis reports. And when you go through a report, what clinician should understand, what the andrologist has assessed the sample and given the report. So beginning with this, first we'll understand how the semen analysis is done. So briefly going through that, we'll be understanding how to understand how to read the report as such. So currently we are following the 6th edition WHO manual 2021. So these are the guidelines that are being followed to assess the semen analysis. And this is a detailed guideline for the andrologist to assess the sample and depending on the quality, quantity, and report the same. So first we have something for the history, that is like the married life and the number of years of trying to conceive. And coming to the analysis part, we will have analytical part, which is macroscopic and microscopic. So macroscopic is something where we assess the volume and the viscosity and the pH is checked. Coming to the microscopic, we actually examine the sample under the microscope to know what the count is, the motility and the morphology. So the results of a semen analysis will include measurements like the quantity and the quality of the semen and the sperms. So this will include the volume. So the amount of semen that is given by the person is assessed. So you will know how the ejaculate is. So, and then coming next would be the sperm count. So the number of sperms per milliliter that is how it is assessed. So you will know how many sperms are there, and the sperm movement, which is also known as the motility, and we'll be seeing how many sperms are moving. So you need live and motile sperms for assessing the sample, and for the further procedures, like if you're planning any IUIs or IVF or anything like that. So based on how the count and movement or motility is, we can decide what the procedure could be. Then coming to the sperm shape, that is also known as morphology. So you should know how the sperms look like. That is what the andrologist will assess. The morphology would be in detail, like the head of the shape of the head, the wippies, tail. And then we also assess if there is any infection by seeing white blood cells, RBCs, or anything like that. So further, we'll go into detail how each of this is analyzed and how we will understand a semen analysis report. So this is what a basic semen analysis report looks like. So this as we discussed, we'll be seeing the guideline, or we'll be following the guidelines from the WHO 6th edition 2021. And so the first investigation would be the date of collection, that is which date the sample has been collected. And some centers also note down where it is collected, maybe at the center or it was a home collection. And second, you can see abstinence period, that is the number of the gap between the ejaculation. So that is also important. And the method of collection, whether it is maybe a normal ejaculation or it's any other special procedures are required, like maybe electroejaculation and all those things. Maybe a vibrator help. Maybe if the person is not able to ejaculate normally, so we take a help of a vibrator or something. So that is what we write under the collection method. Then we will go into macroscopic details, as we discussed: volume, pH, appearance, how it looks like, how the color is, the liquefaction time, that is when the sample is given and until the viscosity is down or normal, that is noted down as the liquefaction minutes or time. And then we also have to note down about the viscosity, whether it is viscous or normal. And then we go into microscopic details like concentration and the total number of sperm that is available, aggregation, agglutinin. So here further we'll discuss each step, how the samples have been analyzed. So the first thing is when the sample is given, liquefaction is important. So what is liquefaction? It's a waiting time wherein we have to note down that there is no viscosity in the sample. So normal liquefied ejaculates will be, maybe there'll be few gelatinous bodies, but otherwise it should be a normally not a viscous sample. So how do we know that? Is the presence of when you pipette or use a pipette to draw the sample or aliquot the sample, the thread should not be more than 2 centimeters. So that is how you'll be noting down the viscosity and the liquefaction time. So the time of the sample that have been collected till the time of liquefaction or analyzing, that should be noted down. And if it is not, then we need to wait for another 30 minutes or maximum 60 minutes, and then the final report should be given. So this time, when it is reported in the semen analysis report, we'll have to note if we are seeing there's too much of time during the liquefaction for an andrologist to prepare, for example, for an IUI or IVF or any other process like that, they'll be expecting this kind of waiting time. So if there is in the analysis report, if that is so, it would be the same almost during the second ejaculate or during the final procedure like on the day of IUI or IVF. So that is the time of liquefaction. Then we move on to the abstinence period or the macroscopic details. So here the volume we'll discuss now in detail. This is like the normal sample should be 1.4 ml or more, and it can range up to 5 ml as well. So if it is more than 5, we term it as hypospermia. So when you are in a report, when you're seeing something like hypospermia, that will be something with the volume is more than 5 ml. And then we can also assess if it is a retrograde ejaculation, or if there is any ejaculatory duct obstructions or any congenital anomalies are there, if the volume is too less or too more. So all those things can be assessed while seeing the volume. And then if we have low semen volume, then the indication would be, or something that can we can access that maybe it cannot neutralize the vaginal acidity. So if the volume is too low, so that is termed as hypospermia, too low. The volume is less than 1.4. Now coming to hypospermia, here there are like the volume would be a little more, so it can be more than 5 ml. So if there is increased in the ejaculate volume, it would be maybe due to some factors like age or genetics, or maybe the person has had more water, or even the sexual abstinence days. So even that long period of time can actually increase the volume. Then coming to the pH, pH is the balance between alkaline secretion of the seminal vesicles and the acidic prostate secretion. So that is how pH is assessed. And the pH value should be somewhere 7 point. It should be like around 7.2, and we assess by using a pH paper and the color coding present there. So we cannot exactly determine the to the point level, but commonly used is the pH paper. So if a pH value is under 7.2, it may be an indicative that there's a lack of alkaline seminal vesicular fluid. Or it can also be due to urine contamination. So that will give you if the pH is under 7.2, that you can assess if there is any urine contamination. So, and if there is an increased pH, it can be due to a long time of incubation, or after the collection, and this will also decrease the natural buffering capacity of semen. So that is again when the pH is too high or too low. If that has been indicated in the pH in the report, that the pH is not normal, then this could be some of the following reasons. And if there is a decreased pH, it could be because of prostatitis or due to even low semen volume. Then coming to the next factor that is present in the semen analysis report is about viscosity. So a normal sample would be smooth and watery, and it should come out as discrete drops from the pipette that you are using. And the threads should not be, or the threads that are being formed should not be more than 2 centimeters. So if it is more than 2 centimeters, you're seeing a long thread like indicated in the picture there, then that you can term it as viscous sample. So why we need to have you note down the viscosity is because if there is maybe due to if the sample is viscous, you can add media and liquefy the sample, or wait some more time and then liquefy the sample. So when you're washing the sample for IUI or IVF or ICSI, then if there is any sample that viscosity is high, you can the andrologist can take certain steps to correct the viscosity by adding media, or by waiting for a little longer time, up to 30 minutes or so, and then do the needful. And then this viscosity again is graded on the scale of 1 to 4. So 1 being the least and 4 being the maximum. So that is how the viscosity is noted down, and we need to see if there's viscous or not in the semen analysis report which has been issued. So as the abnormal sample will be something like long threads, and high viscosity will be slowing down the sperm movement. So when we are washing the sample for IUI, IV for ICSI, certain steps that the andrologist can take and correct the or improve the movement of the sperms as such. And because this viscous sample can also be due to certain reasons like insufficient mixing. So if the sample is not mixed well, what the andrologist can do is aliquot, mix well, and then aliquot the sample again and assess again. So when the viscous sample, you will be incorrectly counting the motility and the total motility or the progressive, non-progressive sperm that the andrologist is noting down. Again, that would be not correct. So viscous samples should be liquefied correctly and then aliquot, and then do the motility count and other parameters can be noted. And if it is a high viscosity, as we discussed, we can dilute it with heavy buffer or sperm wash media. And then whatever the dilution you have used, you can calculate it and count accordingly. And another step would be incubating at 37. Even that brings down the viscosity. And if there is clumping seen, which we'll discuss a little later in detail, so even that will hamper, that will be again the count that we are doing will not be proper. So moving on, we will discuss how that will be done in the later. So coming to the microscopic details now, the first one would be sperm count. So we express the sperm concentration in million per ml, and also the total number per ejaculate is noted down. So here is what WHO manual throughout the years from 1980 to 21. So currently we have volume, which is by WHO 2021, it's 1.4. That's and more is defined. And vitality, that is the number of live sperms or alive sperms, is 54%. And you can see from the from 1980 to 2021, there has been changes there, where it was more than 75, then 2010 it was 58, and now it is 54%. Morphology, normal forms, as you can see through these years, have decreased, and from the current or from even the 5th and the 6th edition says that it should be 4% or more. So the normal forms percentage has been calculated and reported. And then we have others like a sperm count, total count, motility, which we'll discuss a little later. So coming to the count, we have the technique as such is to count under macular chamber, which has grids, and within each grid we have to count the number of sperms, and average is taken. Different fields are selected, maybe 3 rows or 3 columns, or randomly 3 rows and columns should be assessed, counted, and then we have to take the average. So coming to the definition, if we have oligospermia is a condition where we have the count is less. So here previously we have seen the sperm count as per WHO should be around 16 million. So if we are seeing count of 15 million, it is termed as oligospermia. Again, oligospermia has different variations, wherein we have mild, moderate, and severe. And you can see concentration from 15 to 5 has been graded as mild. It comes under mild oligospermia. And moderate is something where between 5 to 1 million. And then we have severe oligospermia, where it is less than 1 million. So that is this is actually not really defined by the WHO, but this is what is commonly followed across the IVF labs or Andrology. So this is mild, moderate, and severe according to the count, and this will all be a class of oligospermia. So here we have sperm disorders. So greater than 16 million or more should be normal, and less than 15 million or so will be falling under oligospermia. And there is also something called as cryptozoospermia. So that is a condition where we will not be able to see the sperms in the fresh ejaculate as such in the raw sample, but there will be sperms when you have centrifuge the sample. So when the sample is centrifuged and we obtain the pellet from the centrifugation, after the centrifugation, we'll be able to notice 1 or 2 sperms there. So that is a condition called as cryptozoospermia. So again, redefining it, it would be the sample wherein, or the condition wherein there are no sperms seen in the fresh ejaculate as such, but seen only after centrifugation or in the concentrate or the pellet. So that is termed as cryptozoospermia. And we have azoospermia. Azoospermia is we have no sperm seen in the fresh ejaculate nor in the pellet. So minor difference. So any suspected azoospermia or the samples where we are not able to see any sperm throughout the field. The second step the andrologist would take is to spin the sample, obtain a concentrate or a pellet, and observe the pellet as well. So as defined, azoospermia, you will not be able to see sperms in the after the centrifugation as well. So these are some terms related to the count. You have oligozoospermia, you have crypto-azoospermia, and different variations of oligozoospermia. So moving on to the next definition or the next parameter. So under microscopic details, we'll be able to see total number per ejaculate. So it will be the volume that has been collected and multiplied by the sperm concentration. So if, for example, if there are 16 million sperms in per ejaculate, that is what your count is, and that is what has been reported, and the volume is around 2 ml. So it will be 16 into 2. So that is the total number of sperms that you'll have. So that is also calculated and reported. So according to that, we'll be able to judge how many sperms will be there for a certain process like IUI or IVF, and then decide what would be suitable for the particular patient. Then moving on, we have aggregations, agglutination, and granular. These are apart from the sperm. So once you have done counting and seeing the sperm's motility, and you also have to note down certain other elements that are there in the sample. So this is something called as sperm clumping. So if there are there are two different types of sperm clumping that we need to assess. So you'll have sperm aggregates. These sperm aggregates are either they are just immotile sperm that have been attached to each other or to a mucus strand or any other debris or a non-sperm cell, and they do not have any specific aggregation. So that is assessed as sperm clumping. So you have, as you can see in the picture here, there are some cellular debris. It could be some cells or anything like that. So the sperms attached to these debris and cells, and these are immotile usually because they are kind of clumped with the cells or epithelial cells or any other debris. So you do not count these. So even though the sperms are there, these aggregates are the sperms that have been attached to the aggregates are not counted. So that is one parameter that has to be looked into and which is assessed and reported. And then you have something called as agglutination. So agglutination will be sperm to sperm attachment. Aggregation is sperm to any other element that could be a cell or a debris, and agglutination is sperm to sperm. So you again have different degrees of agglutination. You have isolated, maybe less than 10 sperms in agglutinate, and moderate would be something like 10 to 50 sperm per agglutinate. Agglutinate is like just one group of sperm that have been attached to each other. And then you have large agglutinates wherein it's like more than 50 sperms would have been attached to each other. And then you have cross, maybe like majority of them, more than 50% to 60% or more, would be interconnected, so forming a agglutinate. Again, you in agglutination, you have different variation. It could be head to head, wherein you can see in the first column where the sperms are attached head to head, or tail to tail, tail heads, tail to head. All these variations have to be noted down. And in the you can see in the picture there are many mixed, wherein you are not able to identify whether the head, there is too much of clumping or aggregations are there, and you're not able to assess the head to head or tail to tail or head to tail. These are being kind of tangled there. So the last category would be tangles. So it is like huge groups of agglutinate which has been they are in tail to tail agglutination. So these are what the andrologist would see and report, and this could be due to maybe anti-sperm antibodies, presence of those, and maybe further if you are seeing abnormally high agglutination, then the further test can be evaluated by doing a maybe anti-sperm antibody test. So in a usual routine semen analysis, that is not done. So in case a semen analysis has been reported having high agglutination, you can follow it by the second the test that we just spoke about. Then the next parameter would be sperm motility. So once you are done with counting, and we also have understood what the different parameters are kind of discussed, or variations of counts, oligozoospermia, crypto and azo. Coming to motility, we term it as asthenozoospermia. So it is defined as when you have less than 42 sperms motility, that is the total motility would be less than 42, and the progressive motility would be less than 30%. So this is what is defined as asthenozoospermia. So one of the parameters, either the total motility or progressive motility is less, or both are less, it will be falling under the asthenozoospermia category. So progressive motility is referring to the sperm moving, the movement of the sperm as such. So here under motility, you again have different classes. You have rapid progressive, which is defined as A, and it is expressed in terms of percentage. You have slow progressive, you have non-progressive, immotile, and the total motile, that is A plus B plus C. So you will also have rapid plus slow progressive and the non-progressive. And altogether, that is a total motility. All progressive also should be noted down. So these are the different, on the right hand side, you can see different definitions there. So that have to be calculated individually and report. So coming to definition of like how exactly do you know it is a rapidly progressive or slow progressive or non-progressive? So coming to those, when the embryologist is seeing the sample under the microscope, you should be able to kind of define them into this particular classes and calculate accordingly. So if the sperm is moving actively, whether the line and the line is linear, the movement is forward, it's not in circles, it's in either it is linear or in very huge circle. So that is termed as rapid progressive. And we need to also, when we are doing a manual assessment, then we'll not be able to calculate exactly how much the speed is. But in cases where CASA is involved, that is computer assisted semen analysis, that will be able to help you calculate these rapid, slow, and non-progressive data. So it will be subjective when you are seeing a rapid, when manually semen analysis is done. Because there are different speeds or so many sperms to assess and see, and classifying them into rapid, slow progressive, and non-progressive should be done at a time and should be assessed properly. So CASA is a much more better way to do it, to especially accurate in terms of noting down all this rapid, slow, and non-progressive. So why we look into this is rapid progressive are those sperms which are active. And if you, for example, if the patient wants to do IUI, so we need, if the rapid progressive is good enough, the number is, or the percentage is good, then we can suggest a IUI, or it will work out for them. If you have slow progressive, which are be more, or non-progressive, which are more, then maybe IUI will not work. Maybe we can give a suggestion of maybe IVF or 𝐸, something like that. So this is why you need to know what's the percentage of rapid, progressive, slow progressive, and non-progressive. So coming to the definition of slow progressive, it is like the sperms which are moving actively, but they are in a little smaller circles, and the speed that they move with is less than 25 micrometer per second. So that will give you an idea how many active rapidly sperms are there and slow progressive sperms are there. But A and B, that is the rapid and slowly progressive, are both kind of a good indicator, or you can combine A and B to note down how many motile sperms are there and how many will be available, or kind of helpful for maybe IUI, IVF, or 𝐸. So once you have calculated that, you will have a better understanding to what kind of treatment would be better for the couple. And next class would be a non-progressive, that is C, which is less, the speed is quite less than 5 micrometer per second, and they have a very fragile movement. So they will have maybe just tail movements, and there will be no progression. They will be in the same place or moving in small circles. The flagella movement there is not much. So these kind of sperms, usually when you are counseling them, for example, OITI or something like that, these sperms hardly reach the fallopian tube. So what we need, or what we are looking for, is rapidly progressive and slow progressive sperms. And then last would be the immotile. So there will be no movements at all, and they will be stationary, and that is like when they may be alive or not. So there is a separate test when you are seeing immotile. For example, here we need to know if the count is good, and suppose we are seeing a semen analysis report wherein there are more number of non-progressive and immotiles, then we need to do further tests like vitality test or HOS test that will tell you how many live sperms are there. So this will actually help you decide the protocol or the procedure that you want to follow, or the way you will treat the patients, or what kind of ART treatment is required. So coming to the motility, the terminologies that have been discussed is asthenozoospermia. And if there is combination of low count and low motility, then it would be oligoasthenozoospermia. And there is also one definition which is called as necrozoospermia. So even though the count is good or more than 16 or whatever the count is, you are seeing sperms which are all immotile. So at that time, there is no movement at all, no twitching. They are maybe falling all in the category of immotiles and non-progressive. Then that is termed as necrozoospermia. So the definition would be if the sperms are immotile and the vitality test shows more than 54% of dead sperms. So vitality is a test wherein we do, if we are seeing such conditions, like the semen analysis report has says a lot of immotiles, and now we need to know if the sperms are actually alive or not. So there could be chance that immotile sperms are still alive, so we cannot term them as dead. So that vitality test will help us know what is the percentage of dead sperms and live sperms, and maybe the live sperms can be used for some ART treatment. And then there are terms like absolute or complete asthenozoospermia. So we have a count, but the motility is too less or zero. So that time or 100% immotile sperms are seen. So that is termed as absolute asthenozoospermia. So these are the different variations when you come across the motility. So astheno is a general term for low motility. So even though the total motility is more and the progressive is less, even then it is termed as astheno. Either both of the categories should be less, that is 42 and 30. So that will be termed as astheno. Oligoastheno is low count as well as low motility, combination of both the parameters. And necrozoospermia is where there are more of immotile sperms and the vitality test shows more than 54% dead sperms. And complete asthenozoospermia would be a condition wherein all the sperms are immotile and maybe you have got a more percentage of live sperms. Okay, moving on to the vitality. Here we had already discussed about vitality, which is a test wherein we are seeing how many live sperms and dead sperms are there. So the number of live sperms would be available for the certain ART procedure. So vitality is tested then usually when we are seeing less than 40 immotile sperms or the immotile are more. So the percentage is calculated. The vitality test just is a kind of staining method wherein there are different stains which will stain the live sperms and dead sperms separately, and we can assess through the microscope. So sperm vitality, which is like kind of estimated by assessing the membrane integrity. So here going into detail how the vitality is done, it's just we are going to assess the membrane integrity. So the dead sperms will not have membrane integrity, whereas the live sperms will have. So here it is not necessarily routinely done, but when we are seeing more of immotile sperms, this test is recommended. And also in cases wherein there are very poor motility, vitality is a very important test to assess between the dead sperm and the live sperm. So any immotile sperm can be alive or dead. So this test will help you analyze the sample better and will be exactly knowing how many live sperms are there, even though they are immotile. Then it is expressed again in terms of percentage. So you count at least 200 sperms under the microscope and assess them. So we use a stain called eosin nigrosin. And also there's a different type of test doing vitality. It could be hypoosmotic swelling test. So the basic difference here is HOS test. Again, when you assess the sperm after they are being treated with the hyperosmotic solution, you'll be seeing the live sperm which are curled up. So in this test, you can also use the same sperm to do a 𝐤𝐸. For example, obviously IUI will not work out. So these samples you can do a HOS test see the number of live sperms and use them for eggs. But in the other test, that is the other test of vitality, can also be done by 𝐒𝐞𝐦𝐞𝐧 staining. So this will tell you how many live sperms and dead sperms are there. It will be like during the reporting time, but you cannot use the sperms as such. The other alternative is HOS testing, wherein you can use the sperms after the HOS test has been done. So this is about vitality. Vitality is basically will tell you the number of live sperms versus dead sperms, and there are two tests, HOS and 𝐒𝐞𝐦𝐞𝐧 staining. So this is how 𝐒𝐞𝐦𝐞𝐧 smear or stain would look like. So here we have the membrane is not not working as such or not intact. So it will take up this stain and it will appear as dark red and stained or dark pink sometimes. And then the live sperms wherein the membrane integrity is good enough, the stain does not enter the cells and they will look like it will be a white or very light pink. So depending on how the smear was made. And so this is in the picture you can see the darkly stained ones or the red ones are marked as D are the dead ones, and the ones marked as L are the live ones. So coming to the next parameter that we look or that is seen in the semen analysis report is the morphology. So morphology is nothing but the number of normal forms that we have. It should be there are different criteria that have been suggested by the WHO, and that is wherein you will be assessing normal forms, abnormal, how many percentage of abnormal heads are there, what is the percentage of abnormal mid pieces, the number of the percentage of abnormal tails. So these are the four parameters that has been, or the percentage that has been looked into while assessing morphology. So sperm morphology, every aspect of the sperm, that is the shape of the head, the acrosome region, the midpiece, tail, cytoplasmic droplets, all these are included to assess the sperm. So by the guidelines from WHO, this is how the sperm morphology or the classification of sperm morphology looks like. So how the head should be. The head should be smooth, it should be regularly contoured and oval in shape, and there should be a well-defined acrosomal region. So how do you see the acrosomal region is from the stains. So you do a morphology staining. It cannot be assessed from the raw sample. So once you have a morphology slide that has been stained, you need to look into each of the sperm under the HPF, the field that you're looking into, and assess the head, see the shape of the head, the integrity, the contour, and also the acrosomal region, which is important. The acrosomal region should be around 40 to 70% of the head area. So if you're seeing a lightly stained head region, in the head region, a light stain, that will help you differentiate between the acrosomal region and the nucleus as such. So 40 to 70% of the acrosomal region should be seen in order to classify it as normal. And also there should not be any vacuoles present in the head. So sometimes the vacuoles are like small air pockets that could be seen in the sperm head in the maybe acrosomal region or the post-acrosomal region, and that cannot be counted as a normal. So everything right from the shape to the contour to the acrosomal region, everything is noted down. What is abnormal? So if you're seeing acrosomal region that is less than 40% or more than 70% of the head area, then that is counted as abnormal. Then there is length to width ratio. So it should be less than 1.5 or larger than 2. So that is again abnormal. Shape should not be biform. That is, it should be a pear shape. If you are seeing apart from that, maybe amorphous or asymmetrical, or it's not oval or pin, or these are all kind of abnormalities in the head. And the presence of vacuoles, again, those sperms having everything defined correctly, that is, maybe it could have a very good shape, it could have correct mid piece, but then if you are seeing vacuole, that sperm will be counted as abnormal, or any combination of these. And if you go into WHO manual, the shape, different types of head shapes, and the amorphous head that has been a small, it could be giant heads, it could be small heads, it could be oval, it could not be oval, asymmetrical. All these are again abnormal sperms. Then moving to the mid piece, defined by the WHO, it should be slender, it should be regular and about the same length as the sperm head. So anything apart from this will be classified as abnormal. So the major axis of the midpiece should be aligned with the major axis of the sperm head. So if you see it is a pear shaped or oval, the same axis, this midpiece should be aligned. And if there's anything like irregular shape, or if it is too thick or too thin, or maybe at an angle or sharply bent, or any combination of these should be treated as abnormal. And then you have, coming to the tail aspect, the tail should have a uniform calibre along with its the whole length, and it should be thinner than the midpiece and should be approximately 45 micrometer long, which could be approximately be 10 times the head length. And it may be looped back on itself. That could be because of the staining or anything like movements and things like that. And it should not have any sharp angulation, that when you see a sperm tail, it should be long and slender, not bent at any positions. So that would be a normal. And abnormal would be, again, if you are seeing a sharp bend at the tail, that is classified as abnormal. Or things like maybe there are very small heads and hairpin bends, hairpin bend is very sharp, again, bends of the tail, so that is again abnormal. You have sometimes very short or broken tails, maybe of irregular width, and then you will have maybe multiple tails. You can have 2 or 3 tails arising from one head, so that is again classified as abnormal, or any combination of these. So next would be cytoplasmic residue. So these are seen as small droplet-like structure. So if you are seeing in the midpiece or in the tail, all these are classified in the abnormal category. So any residual cytoplasm considered as an anomaly only when it exceeds 1/3 of the sperm head size. So a smaller cytoplasmic residue, if it is less than 1/3, is okay, you can count it under normal, but more than 1/3, again, that will be classified as abnormal. So one sperm, you look into head, its structure, the vacuoles, the midpiece, the tail, cytoplasmic droplet, and so each of the sperms, at least 200 sperms are being counted, and then these are reported depending on the percentage. For example, in the 200, you have seen maybe 30% of head defects, 45% of midpiece defects, and tail defects. All these are expressed in terms of percentage. So each sperm is counted, and a counter is used, and you count each and every defect. And this is a manual way of doing it. If you have a CASA, so this is assessed by the computer, and you get a computer generated report wherein the computer will tell you how many, what's the percentage of head defects, the number of midpiece defects, the tail will be assessed by the computer. So this is a little much more better with CASA because it is less time consuming. When you do it manually, it takes a lot of time to assess morphology, but then depending on the experience of the andrologist, it can differ. But CASA is something which is kind of beneficial and less time consuming when you are assessing the morphology. Then coming to the abnormal parameters in the, concluding the reports, maybe if you are seeing in the report is aspermia, so that is the absence of semen itself. And then azoospermia, as we discussed, it is the absence of sperm in the semen. And oligo is something which is less than 16 million count is there per ml. Severe oligo is less than 5, and you have abnormal morphology. So by the WHO, it is like 4% or more is normal. So if it is less than 4, 3, 2 or 1, that is termed as teratozoospermia or teratospermia. So that is coming under the abnormal sperm morphology. Then if there is a decreased motility, you term it as asthenozoospermia. And if there are more than 54% of dead sperms, you can term it as necrozoospermia. And there are also some terminologies which are actually not in the WHO but commonly seen in semen analysis report is something globozoospermia. Here you will be able to assess the sperms, and there will be very less acrosomal or no acrosomal region, and it will be most of the heads would be round in shape. So globozoospermia. So oval, instead of oval shape, you're seeing majority of them in a round shape with the absence of acrosomal region. That is termed as globulospermia. Then you have oligo-asthenoteratospermia. So that is a combination of low count, low motility, and also low abnormal sperms. So combinations of these all three parameters that have been below the WHO manual, the standard that has been set by WHO manual, you can term it as oligo-asthenoteratospermia. And there are very cases wherein the semen analysis report has maybe less than 1 million, and morphology and motility also would be too low. So that is termed as severe OATS or severe oligo-asthenozoospermia. So here this is extremely low count, extremely low motility or pitching motility, maybe no rapids, no progressive, maybe only non-progressive, and terato, wherein usually these such samples that is very low count and low motility will probably have a very low normal number of sperms. So again, and you will not also have more 200 sperms to assess them. That is because of the low count. Then you can term it as severe oligo-asthenoteratospermia. Then other conditions like hyperspermia, hypospermia, that we have already discussed. Then there is something like pyospermia or leukocytospermia. So according to WHO, this it is defined as when the sample has more than 1 million WBCs per ml. So when you are assessing the sample along with the count, motility, morphology, other elements like WBCs or RBCs or any other debris or things like that should be noted down. And that is if the count of WBCs is more, then we term it as leukocytospermia. And similarly, if the RBC is seen in the sample, it is termed as hematospermia. Even the color of such samples would be slightly reddish, and the samples when seen microscopically would be, there should be like few cells of RBCs. So then you can term it as hematospermia. So then you can look into what the condition would be. It could be some due to some infection or UTI or anything like that. So that when you're seeing such reports, then further analysis maybe regarding to infection or anything can be assessed. So maybe if there are too much of WBCs, you can a test for semen culture can be asked for, and hence you can define what the infection or any other parameters can be looked into. Then you have polyzoospermia, again not defined by the WHO, but normally used. So it would be a condition wherein there are abnormally high sperms. So according to WHO, the current one, it says it defines polyzoospermia as more than 250 million sperms per ml. So the WHO 2021 has defined this. Previous few editions did not have such terms as it. There would be only oligo, astheno, terato, and this certain terms like pyospermia, polyspermia, globulospermia has been added of late. So coming to the next parameter that is there in the semen analysis report is called as teratozoospermia index or TZI. So we'll look into what exactly the definition is. So here is the number of the malformations that have been detected in each part of the sperm. So the andrologist can calculate how this TZI is by calculating the anomalies in the head, the anomalies in the midpiece, and the anomalies in the tail, and then which is added up and divided by the total number of abnormal sperms. So what this TZI would give you a number ranging from 1 to 3. So wherein it refers to the anomalies present in one part of the sperm. So if like a sperm is affected in its head, affected in the midpiece, affected in the tail, so that is a little high TZI. Or what we can say is most of the parts of the sperm are not normal or abnormal. So that is defined as TZI, and maybe the TZI is low. Maybe 1, it is a better quality, or the quality may be a little better rather than a TZI which is 3 or more. So that could be higher defects seen in the sperm, in each sperm. So when all these reports have been assessed, here we have like semen analysis workup. So, for example, the semen analysis workup, you have found that the count is normal, the motility is fine, the morphology also looks fine, it's more than 4%. So maybe we can assess a DFI. So DFI is DNA fragmentation index, wherein most of the sperms will look normal, but they might have a high fragmentation of the DNA. So that can be also assessed in usually in cases wherein there are IVF failures, everything looks fine, the parameters are showing normal zoospermia, and there are recurrent maybe abortions or IVF failures. So then a DFI test could be done. So it will tell you the number of the fragmentation, the DNA, the content that will give the actually the quality of the DNA that has been carried to the egg. And hence, even if the DFI is high, the embryo quality would be not that good, and it could lead to abortions or miscarriages and things like that. So if a normal parameter or all the parameters of the semen is normal, then maybe a DFI could be suggested. And if there is, even that turns out to be normal, so there's no additional workup. So it looks like the things are fine there from the male factor, provided that there is no other things like sexual dysfunction, maybe EDF or something like that. So next, it would be if the volume is less, then it could be maybe because of incomplete collection or partial retrograde ejaculation. So we need to look assess into that and do the necessary measures. So, and if it is a retrograde ejaculation, then we need to also do a microscopic analysis of the post orgasmic urine. So that will, if there are sperm seen in the urine, then it can be defined as retrograde ejaculation. Then certain next would be, we are looking into the concentration or the count that we have. So if there is very low or decreased sperm concentration, things like scrotal or blood tests like testosterone, LH, FSH, inhibins can be assessed. Like for example, in azoospermia cases or severe OATs, severe oligoasteroid teratozoospermic samples. So this, if it is azoospermia, scrotal scans can be done. That will help you analyze better what the condition is. And then abnormal morphology, wherein you have, if the morphology is too little in spite of the good count and motility, there could be possibly any genetic reasons behind that. So a karyotype or something can be done to assess the morphology. And certain different washing procedures, for example, if there is a high DFI or the motility, morphology is too bad, maybe 1% or something like that, we have washing procedures like density gradient methods, wherein it will kind of decrease the number of when the post-wash sample, there should be a decrease in the improvement in the quantity that we have received after the washing. So here in the DG process, what happens is most of the morphologically abnormal sperms, dead sperms, and high DFI sperms does get eliminated out very efficiently. So the post-wash sample should have a better quality with respect to the morphology and also the DFI. And there are certain other procedures like MATS, wherein we are kind of magnetically sorting the cells. So this will, again, there's a different procedure wherein we have chemically activated certain sperms, and these get the ones which are carrying high DFI gets eliminated out, and what we get at the end of the procedure would be better quality sperms in terms of morphology as well as DFI. So this, if the morphology is too low, certain other procedures can be done like density gradient or MATS. And after seeing the semen analysis report, seeing the count, the motility, the morphology, and other parameters like aggregation, agglutination, viscosity, or things like that, you can assess which process or which protocol or which ART treatment would be better for the couple. So if the IUI has been planned, if the sample is good enough, for example, if you're doing or if you're trying to counsel the patient for an IUI, at least the normal sperms, the number of count should be good, and the total motility or the progressive and specific should be better, and the morphology should be at least 2 or 3 or more like that. And so that if the count is too low, maybe severe OATs, then doing IUI would not be beneficial for the patient. So then you can decide maybe IVF or 𝐸C. So the semen analysis report will help you analyze from the male factor aspects and suggest the ART procedure that you want to go for. And now if we are seeing kind of borderline or mildly abnormal parameters like mild astheno, or it could be a mild terato, or it could be just mild decrease in maybe 10 million, 12 million, maybe an IUI could work out for them. So you need to also know the volume. So if the volume is fine to 1.4 ml or more, and then the count is okay, 10 to 12 million, even though it was terato, maybe a IUI could be beneficial. And doing the process, even for the andrologist or the embryologist to process the sample, like for example, doing maybe planning a density gradient method or combination of DG and 𝐸𝐶. So this semen analysis report will help you decide what kind of procedure would be better for the couple. And so we all have two different washing procedures. We have 𝐸𝐶 method, we have density gradient method, and 𝐸𝐶 is somewhere like kind of mimics the natural movement of the sperms. So if you're seeing the count is good and the motility is good, the rapid progressive is good enough, and the total motility is also more than 42%, then you can try a 𝐸𝐶 method, wherein it is like a simple centrifugation is done, the pellet is formed, and you layer the pellet with the media. So the sperms have the capacity to swim up and get collected in the media that is there. And this sample or this media can be used for IUI. So that is the 𝐸𝐶 procedure. Here, then again, viscosity will play a role. If the viscosity is high, then maybe this will not work out. You need to do a density gradient. Or if you're saying the total motility is good enough, for example, if it is 60%, but the rapid is less than 30% or so, then again, this 𝐸𝐶 method will not help. A DG method or a density gradient method is much more beneficial. So knowing how the different classes of motility is and the count as well will help you decide what kind of the treatment done, as well as the washing procedure. So it will help the andrologist and the embryologist to decide which method would be better for these patients. And again, as we discussed, like if the viscosity is more, then maybe adding media or any liquefying agent, enzymes also help in bringing down the viscosity. So in the report, if there is certain things like that, then taking necessary action and step will help improve the quality. So at the end of the procedure, whatever IUI, or if you're planning IVF or 𝐸C or anything like that, the washing procedure ultimately helps improve the quality, and certain the parameters that have been reported in the semen analysis report, certain conditions that have been seen in the report will help the andrologist or the embryologist to process accordingly. So this is how you can take help of the report and do the maximum benefit for the couple. And the thing for IUI would be, it should be the prepared sample or the final sample should have at least more than 10 million sperms per ml, and the morphology at least should be 4%. So basically we are this IUI would be kind of close to the normal conception. It's just that we are bypassing or we are eliminating any hindrances like zinc or prostaglandins, washing out all the immotile, and even the sperm washing media helps in activating the sperms, or capacity the capacitation is there, and then that will help if there is high viscosity, the sperm, when we remove all the semen, plasma and everything, the motility does improve. So the final sample or what we are using for IUI should be at least more than 10 million with a good motility, around 90% or more post-wash, and good morphology. So that will increase the chances of a successful IUI. And then planning for 𝐸C or IVF, it couldn't be done in case the report says azoospermia or severe oligoastenospermia or severe oligospermia. All these parameters, if they are reported in the semen analysis report, then maybe you can plan for 𝐸C and IVF. So depending on how the count is and the total number of motile sperms that we have, the rapid in particular would be helpful in analyzing what kind of procedure can be done.
Welcome you all. The next topic, male reproductive system and spermatogenesis. When it comes to infertility, we should remember that male infertility equally contribute almost 40 to 50% as similar to female component. WHO mentions that 48 million couple and 186 individual live with infertility. It means 1 in 7 couple are infertile. Addressing infertility is very important part of realizing every couple and individual to find their family. Let me introduce to the male reproductive system and spermatogenesis. Male reproductive system includes external genitalia, that is penis, scrotum and testes. Testes involves seminiferous tubules and epididymis. Ducts which receive and transport gametes are vas deferens or ductus deferens and ejaculatory duct. Accessory glands which help in secretion, Cowper's or bulbourethral glands, seminal vesicle and prostate. The genital system develops from the following sources, that is intermediate mesoderm, that is kidney, ureters and reproductive system. Coelomic epithelium covers the intermediate mesoderm. Coming to the development of male reproductive system, development of genital system starts on the day 1 or day 0 itself. The genital sex can be identified at the time of the fertilization itself. But the gonads are undifferentiated till the 6th week. By 12th week, the external genitalia are developed. By the end of 20th week, the phenotypically differentiation will be completed. The primordial germ cells, we can see that it has been externally located and it gets located. The primordial germ cells arises at the wall of yolk sac near the allantois. It starts migrating from 4th week and reaches by 5th week and invades the genital ridge by 6th week. How is the differentiation happening between male and female gonads? By 2 factors, that is, one is chromosomal, the second is hormonal factors. The most important being the SRY gene, which is located in the short arm YP11.2. That is the most important factor which determines male gonads, and that will also help in initiating the downstream cascade and helping the initiation of the testis development and the hormonal factors coming to testosterone by the Leydig cells. We can see in the testis that the primitive sex cords, which has been mentioned in the testis, that is medullary cords, in males form the seminiferous tubules, and at the end of 16th week they find the canalization and drain to rete testis, and rete testis drain to duct of epididymis through efferent tubules, and finally to the ductus deferens. When it comes to females, the paramesonephric duct start developing, and these medullary cords transfer as ovarian follicles. The paramesonephric duct or the Mullerian duct gets regressed by 6th week in males because of the influence of AMH and hormone testosterone. And when it comes to females, the Mullerian duct develops and the female genital organs develop. We can see the differentiation here when it is synonymous from testis to the gonads in males, ovary in females, and the seminiferous tubules as ovarian follicles. Granulosa cells can be seen as similar, synonymously. Coming to the descent of the testis, there are 2 sources, that is the transabdominal and inguinoscrotal. In transabdominal, the gubernaculum, which has been attached to the retroperitoneal structure, and it helps and prevents the ascent of the testis. And by the end of 3rd trimester, the testis is being descended, and then it will become the extra-abdominal organ. The whales, sharks, elephant, and the hippopotamus has their spermatogenesis occur in the abdominally, but in humans, it is extra-abdominal, or it is being because of the cooler temperature. Coming to the structure of penis, it has a root, body, and glans. Root being the most proximal fixed part of the penis, the root contains 3 erectile tissues, 2 crura and the bulb of the penis, and 2 muscles, that is ischio cavernous and bulbospongiosus. body, the free part of the penis is located between the root and the glans, and glans being the most distal part of the penis, it is conical in shape and is formed by the distal expansion of the corpus spongiosum. So we can see the crura on the right side of the picture, the crura of the penis, that is the root, and the bulb of the penis, corpus spongiosum and corpus cavernosum. The same picture depicted here. We can see on the left hand side on the first picture, both the corpus cavernosum to erectile tissues and corpus spongiosum where the urethral is being draining to. On the right side, it is the flaccid and the erectile state. Anatomy of the scrotum. The scrotum is a pouch-like structure that hangs behind the penis. It holds and protects the testis. It is very sensitive because it contains numerous nerves and blood vessels. The scrotum has following layers, that is skin, dartos fascia, external spermatic fascia, cremastic muscle, internal spermatic fascia, and tunica vaginalis. The cremastic muscle function is to raise and lower the testis in order to regulate scrotal temperature for optimal spermatogenesis. The scrotal skin is very thin, rugosity is very high, and it is pigmented. It is all because for the increased the surface area to get increased. We need to ask during the history of male, of the occupational history especially, because whenever there is more of heat exposure, the cremastic muscle gets contracted or raised up, so the spermatogenesis can get impaired. So history of occupation in males is very important. Coming to the anatomy of testes, the testes are covered by tough membrane shell called the tunica albuginea. We need to remember here the tunica albuginea is most densest and thickest connective tissue in the body available, and also the testes contain the following tubules and ducts: the seminiferous tubules, rete testis. Lobules vary 250 to 290 in a single testis. The lobules are conical in shape. We can see on the right side picture where the base is conical and the tip will be at the lumen. So the lobules are conical in shape, the base being directed towards the circumference of the organ, the apex towards the mediastinum testis. Each lobule is contained 1 to 3 seminiferous tubules. We can see the cut section here that at the base, we can see the spermatogonium, and at the lumen, it is the matured spermatids and the sperm cells, which has been processes happening. When it comes to blood supply of the testes receive their arterial supply from the testicular artery, cremastic artery, and the artery of vas deferens. Testicular artery is being derived from the aorta, cremastic from inferior vesicle in superior mesenteric artery, and artery of vas deferens from inferior vesicle artery. And when it comes to venous supply, it is the interconnection of the veins, which is called pampniform plexus, drains to the testicular vein, cremastic vein, and vasal vein. This is regarding the varicosity. Varicocele and subfertility is a huge topic, but in brief, altered heat exchange mechanism due to stagnation, hyperthermia can inhibit spermatogenesis. When increased temperature and increased metabolic activity, it depletes the glycogen storage and injures of parenchyma and leads to oligospermia. Hypoxia and Leydig cell dysfunction can lead to low androgen synthesis and maturation arrest, which can lead to poor spermatogenesis. The epididymis is a tube that connects the testes through the vas deferens to the vas deferens. It's a narrow, tightly coiled tube. The epididymis can be divided into 3: the caput, the corpus, and the cauda. Immature sperm cell formed in testis travel towards tail, undergoes maturation, and gain the property of motility and fertility. What is important in epididymis is during trial PESA or PESA process, the most important, the mature sperms are being during the surgical retrieval can be gained here. So when we see the anatomy, epididymis is very important. The vas deferens is the duct which transports sperm from the epididymis to the ejaculatory duct, which is 30 centimeters long, 3 to 5 millimeter in diameter. During ejaculation, the smooth muscle in the wall of vas deferens contracts reflexly and thus propels as like peristalsis. So we need to ask in secondary infertility especially about vasectomy, and any injury to the testis can also affect the injury to the vas deferens. So history of vasectomy, injury to the testis is important. Coming to the accessory glands, there are three main accessory glands, that is seminal vesicles, prostatic gland, Cowper's gland, and urethral glands. The products of these glands which will be nourishing and activating the spermatozoa. It is to clear the urethral tract prior to ejaculation. It also can serve as the vehicle of transport of the spermatozoa in the female tract, to plug the female tract after placement of spermatozoa to help the fertilization. Seminal vesicles are a pair of glands which can be seen at the bladder wall, posterior to the urinary bladder wall. These seminal vesicles are the excretory ducts of each seminal gland will be uniting with a vas deferens and form the ejaculatory ducts. Now, it is the major component to contribute for the semen. It is almost 70 to 85%. It is alkaline, and alkalinity of semen, why is it important? Because it neutralizes the acidity of the vaginal tract and also can help in the prolongation of the lifespan of the sperm. Coming to prostate, it surrounds the urethra just below the urinary bladder. The prostatic fluid is slightly alkaline. It means more of acidic content. Usually it constitutes 25 to 30% of the volume of the semen. The prostatic fluid is expelled in the first part of the ejaculate together with the most of the sperm. So during the ejaculatory process, these prostate also can contain some smooth muscles that also help to expel semen during ejaculation and merge with two ejaculatory ducts. These bulbourethral glands are responsible for producing pre-ejaculate fluid, and which is secreted during sexual arousal, lubricating and neutralizing the acidity of the urethra in preparation for the passage of sperms. So you need to know, during the pre-ejaculate fluid, it will be bulbourethral glands which will be helping it. During the first sample or the first ejaculate, it will be the prostate, and lastly will be the seminal, which will be coming from the seminal vesicles. So during ejaculation, the semen passes through the prostate gland, enters the urethra and exits the body via urethral meatus, which can be seen in the picture here. Coming to the spermatogenesis. Spermatogenesis is the process wherein which the haploid spermatozoa develop from germ cells in the seminiferous tubules of the testis. We can see that the germ cells are being at the base of the seminiferous tubules. This process starts with the mitotic division of the stem cells located close to the basement membrane called spermatogonia stem cells, that is SSC. The mitotic division of the stem cells produce two types of cells. Type A cells are also called dark cells, replenish the stem cells, and type B cells are differentiate into primary spermatocytes. That is the one which gives the primary spermatocytes. Type A can help only in producing the type B cells or self-replicating as type A cells. It's the primary spermatocytes which come only from spermatogonia B. So the primary spermatocyte divides meiotically into two secondary spermatocytes. Each secondary spermatocytes divide into two equally haploid spermatids by meiosis II. Every spermatogonium A can give rise to 4096 spermatids. So, but what happens is, it is because of the apoptosis that most of the spermatids will be not coming into the lumen. And every cycle will be taking at least 16 days each because in the seminiferous tubules, each will be having 6 stages. So every stage will be taking 16 days each. This can be seen here. These are the 6 stages of the spermatogonia. The site for spermatogenesis is seminiferous tubules. They are lined by stratified germinal epithelium and contains supportive cells or the Sertoli cells. 5% of the testicular tissue is by Leydig cells, which are being in the interstitial tissue. The cross section can easily show 4 to 5 different generations of germ cells. The younger ones will be at the basement area, where the mature ones will be at the lumen, which can be depicted in the picture there. These develop, or whatever is the spermatids, develop into mature spermatozoa, also known as sperm cells. The Golgi phase that is the Golgi body enzymes form the acrosome. So the acrosome condenses around the nucleus, and the tail phase, which is the centriole, elongates to form the tail, and maturation phase, where the loss of excess cytoplasm will occur. So we can see on the right hand side the mature head, midpiece and the tail. The spermiation is the resulting spermatozoa are now mature but lack motility and rendering them sterile. So the mature spermatozoa are released from the protective Sertoli cells into the lumen of the seminiferous tubule in a process called spermiation. The non-motile spermatozoa are transported to the epididymis in testicular fluid secreted by the Sertoli cells with the aid of peristaltic contractions. While in the epididymis, it gains motility and becomes compatible of fertilization. What is the role of Sertoli cells? It is to maintain the environment necessary for development and maturation sperm. It secretes the testicular fluid, it secretes ABP, that is androgen binding protein, inhibin, phagocyte, the residual cytoplasm left over after the spermiogenesis. It protects the spermatids from the immune system of the male via the blood testis barrier, and it also contributes to the spermatogonial stem cell niche. So we can see the spermatogonium, primary spermatocyte, secondary spermatocyte, and the early spermatids on the picture. The role of Leydig cells. LH acts at the Leydig cells and stimulates synthesis and secretion of androgens. Androgens in turn stimulate the process of spermatogenesis. The role of prolactin in Leydig cells is it increases the response of Leydig cells to LH by increasing the number of LH receptors expressed on Leydig cells. This is the hypothalamo-pituitary testicular axis where the GnRH from the hypothalamus is released and activates the release of gonadotropins, the FSH and LH, which help in production of testosterone, dihydrotestosterone, estradiol from Leydig cells in testis, and inhibin and activin. Once the production of testosterone and the androgens is being increased, it gives negative feedback over the pituitary and hypothalamus, and this goes on vicious cycle. Coming to neuronal mechanisms, orgasm is the culmination of sexual stimulation accompanied by emission and ejaculation. Erection is a parasympathetic nerve impulses. The blood gets accumulated in the erectile tissue of the penis, and ejaculation is a sympathetic nerve response. There are two process. One is emission. Emission is the movement of semen into urethra. Where it comes to ejaculation, it is the movement of the semen out of the urethra, and it largely depends, I told you, as sympathetic nerve impulses. What is the mechanism of penile erection? When there is sexual stimulation, the parasympathetic neurons release the nitric oxide, causing all this dilatation of the small arterioles to the penis, and this compress the veins and reduce the blood flow away from the penis, and this blood gets accumulated in the vascular spaces within the erectile tissue of the penis, and thus penis swells and become erect. This is the same picture given, so wherein which we can see the nitric oxide is released, the CGMP formation happens, where vascular smooth muscle relaxation and influx of the blood into the sinusoids. Then what is the mechanism of emission and ejaculation? When the culmination of intense sexual stimulation will lead to sympathetic impulse contraction leading to smooth muscle contractions, peristalsis. Here we need to know the anatomy of male reproductive system, the ductal system and the accessory glands. All three are important for ejaculation. So the peristaltic contractions in testicular ducts, epididymis, vas deferens and ejaculatory ducts, along with rhythmic contractions in erectile column of penis, with rhythmic contractions in bulbourethral glands, prostate glands and seminal vesicles, lead to emission, that is, semen moves into urethra, and then the ejaculation where it is forcefully expelled from urethra. Coming to the sperm structure, sperm is a male haploid gamete. So we need to know in this phases if there is any issue with the ductal system, the anatomy, any injury to the testis. So we need to ask the history of premature ejaculation or erectile dysfunction, and then we can look to the functional modality or the endocrine modality or the anatomical contribution which can help in the diagnosis. Coming to the sperm structure, sperm is a male haploid gamete. It measures about 60 microns in length. So it contains head, neck, middle piece and tail. Head is a pyriform in shape, 4 micrometer in length, derived from the nucleus, which consists of 23 highly condensed chromosomes. Acrosome contains enzymes that help in penetration of the spermatozoa into the ovum during fertilization. Acrosome is made up of glycoprotein and contains numerous enzymes like proteases, phosphatase, and neuroaminidase, and hyaluronidase. The post-acrosomal part of the plasma lemma initiates the fusion of two gametes during fertilization. It is the smallest part. The neck is the smallest part and has the proximal centriole parallel to the base of the nucleus, and it is also distal centriole perpendicular to the previous one. The proximal centriole is present also in the mature spermatozoa. The distal centriole disappears after axoneme assembly. The proximal centriole enters into the egg during fertilization and starts the first cleavage division of the egg, which has no centriole. The distal centriole gives rise to the axial filament, which forms the tail and has an arrangement of 9+2. Coming to the middle piece, it represents the anterior part of the tail. It consists of the core of axoneme surrounded by mitochondria. It has 10 to 14 spirals of mitochondria surrounding the axial filament in the cytoplasm. It provides motility and hence is called the powerhouse of the sperm. Tail is also known as flagellum. Main function is motility. Length is almost around 50 micrometer. Sperm generates ATPs in tail region and use them to provide energy for motility. The ATP are activated by magnesium and calcium ions. So the capacity of motility develops in the sperm during their passage through epididymis, but sperm resort to motility only after being ejaculated into the female genital tract. So we can see the picture by 9/2 in the picture there. The sperm function is the spermatozoa provides genetic information for successful embryogenesis. If the information is incomplete or defective, it leads to abortion of the embryo. Presence of abnormal DNA in sperm nucleuses causes infertility. Why are we so specific about DNA? Is because whenever there is any DNA abnormalities in the sperm, that is when, especially when there is age or occupational hazards, or ROS or oxidative stress is increased, there could be a damage in the DNA. Because of the DNA damage, that leads to incomplete information to the embryo. That is when it leads to abortion. So here we do a DFI, that is DNA fragmentation index, to know how successful can an embryo be formed. So what is the pre-fertilization events and how is the sperm helping out for the fertilization? At ovulation, the cervical mucus increase in amount and becomes less thick, and that is how it allows the easier sperm transport. This passage of the sperm through uterus and oviduct occurs mainly due to muscular contractions of the uterus and the oviduct, and thus it gets stored in the fallopian at the ampullar region. The end of the oviduct comes into close contact with the ovary during ovulation. Fimbria of oviduct ends sweep the ovulated ovum into the oviduct. The peristaltic waves of the oviduct musculature bring the ovum into the ampulla of the oviduct. So we need to remember that it is from the lateral to the medial end where the oocyte has been picked up from the fimbrial end, and it is transported towards the ampullary junction where the fertilization has to occur. So capacitation, sperm cannot fertilize oocytes when they are newly ejaculated. The process of capacitation takes around 5 to 7 hours when sperms are more active, and it occurs in the uterus and oviducts, and it is facilitated by substances of the female genital tract. The acrosomal reaction cannot occur until the capacitation has occurred. The fusion of the sperm cell nucleus with the egg cell produces a zygote. It also activates the egg, triggering the beginning of the embryonic development, brings male and female gametes together to produce diploid zygote. The process of fertilization is sperm makes contact with the egg, then acrosome reacts with the zona pellucida, acrosome reacts with the periphytal in space, and then the plasma membranes of the sperm and egg fuse. And lastly, the sperm nucleus enter the egg. Finally, the cortical granules fuse with egg plasma membrane, which renders the vitelline layer impenetrate to the sperm. Thank you.
So the question is, globospermia is a condition where A, the midpiece has defects, B, the acrosomal region is absent, and C, the head is round, or D, both B and C. So the correct answer would be D, both B and C. Question 2, teratozoospermia is a condition in which the option A is normal forms are less than 4%, whereas all the other parameters are normal. combination of both low count and less than 4% normal forms, and C, low count, low motility, and D, that is all of the above parameters. So the answer is A, the normal forms are less than 4%, whereas all the other parameters, that is count and morphology, are normal. Question 3, severe OATS is defined as option A, count less than 5 million, poor motility and poor morphology, or option B, count is less than 15 million with poor motility and poor morphology, or option C, presence of RBCs in the sample, and option D, presence of WBCs in the sample. So the answer is option A, count is less than 5 million, poor motility and poor morphology. Question 4, pyospermia is defined as option A, 1 to 2 WBCs seen per HPF, or 1 million WBCs per ml, option C, 1 million RBCs per ml, or option D, 10 to 20 WBC per ml. The answer is option B, 1 million WBCs per ml. Question 5, which of the following is true for TZI, teratospermic index? Option A, TZI of 1 is a good indicator for IUI. Option B, higher the TZI, better the morphology of the sperms. Or option C, 𝐒𝐞𝐦 is preferable for if the TZI is 3. Or option D, 𝐒𝐞𝐦 is preferable if TZI. The answer is A, a TZI of 1 is a good indicator for IUI.
How many seminiferous tubules will be there per testicular tubule? A, 1 to 3, B, 500, C, 1000, D, 10 to 30. Answer is A, 1 to 3. Second question, seventh question, which of the following is wrong? Spermatogonia and Leydig cells are present in seminiferous tubules. Small blood vessels are present along with Leydig cells. Leydig cells secrete androgens. Sertoli cells provide nutrition to the germ cells. Answer A, spermatogonia and Leydig cells are present in seminiferous tubules. It is the Leydig cells which are present in the interstitium, and spermatogonia are present in the seminiferous tubules. Question 8. Sperms are temporarily kept in A, epididymis, B, vas deferens, C, bladder, D, prostate, E, ejaculatory duct. Answer is A, epididymis. Question 9. Which hormone initiates spermatogenesis? A, FSH, B, testosterone, C, LH, D, DHEAS. Answer is A, FSH. It initiates spermatogenesis. What is the question 10? What is the primary function of Leydig cells? A, regulate pituitary secretion of prolactin. B, testosterone synthesis. C, nitric oxide release. D, inhibin secretion. Answer is B, testosterone synthesis. Last question for the day. Erection occurs after activation of which of the following? A, parasympathetic nervous system. B, sympathetic nervous system. C, norepinephrine release. D, serotonin. Answer is A, parasympathetic nervous system.